and sarcopenia causing pain at knee and its management. So osteoporosis and sarcopenia cause failure of load-bearing capacity of joints, thus load falls directly on bones. So as you know, the subchondral bone plays a key role in supporting the articular cartilage mechanically and metabolically and absorbing shock. The fact is the subchondral bone attenuates about 30% of loads through joints, while cartilage attenuates only 1.3% of them. So on weight bearing, the porotic subchondral cancellous trabeculae starts collapsing by microfractures. Healed microfractures lead to subchondral sclerosis. The sclerotic subchondral bone is not viscoelastic and overlying cartilage loses its nutrition and cartilage breakdown may start. So the subchondral sclerosis happens before the articular cartilage starts to wear away. So my point is the cartilage damage was preceded by the subchondral bone collapse. So my study reveals the microfractures of subchondral trabeculae due to osteoporosis gives pain, and pain at knee may be mistaken for OA knee pain. As the articular cartilage is avascular, aneural, lymphatic, its breakdown can't produce pain. So microfractures of porotic subchondral cancellous trabeculae cause pain. So subchondral sclerosis results in intramedullary venous hypertension that gives the major pain at the knee joint. So this lady used to come to OP regularly, and you can see that it looks like the varus bilateral knee. And most of the times the varus knee is involved is not due to medial joint compartment narrowing, but it is due to collapse of subchondral cancellous bone due to osteoporosis, more on medial condyle tibia, which receives the load and weight. So you can see here the X-ray shows the good joint space, and both condyles, lateral medial, got the shape of the convex shape. Due to osteoporosis, and the middle condyle doesn't have any support like lateral condyle with a fibula or head, so it starts collapsing with the peak adduction movement with the knee joint. So the collapse leads to the convex of the shape will convert into concave shape. Slowly looks like a varus deformity, and also the triple plateau also altered, so it looks as if it's narrowed. So the pain at the knee and the varus deformity and joint space narrowing all are the consequence of the osteoporosis and sarcopenia, and results in microfractures and subchondral bone. So this alters the whole picture, the quadriceps pull and the Q angle also. So when routinely we do take the LP and lateral views of the knee in extension, and you see the left side picture shows that there is narrowing of the space, and there is altered shape of the middle condyle. But when you take Rosenberg view, it shows the real shape of the joint. So with this structures, generally I go with this following treatment modalities like unloading of the joint. The main load is because of the sarcopenia, the muscles are not strong enough to take the loads. So the load falls directly on the bone. So already bone is porotic. So you have to unload the joint first and improve the bone strength, improve the muscle strength, and then you can go with the surgery last. So unloading can be done by the change of footwear and giving the support of the knee braces, and lifestyle modification. You can advise the patient not to squat and not to stand for a long time, not to walk for long distances, and you can use ramps instead of steps, and you can use the sticks and all. So with this you can unload the knee joint, and you can improve the muscle strength by doing the exercises and physiotherapy, and improve bone strength by reversing the osteoporosis by giving injection teriparatide. Teriparatide is a recombinant human N-terminal fragment parathyroid hormone. It helps in remodeling of the collapsed subchondral cancellous bone by its anabolic osteoporotic activity, and also increases the bone density. And bisphosphonates also you can give, and the vitamin D3 and rich calcium food and rich protein food can help to reverse osteoporosis. So I can show you some of the X-rays here. Before and after this conservative line of management, you can see that clearly there is a remodeling of the middle condyle which is collapsed already, and you can see that the increased space, the joint space, and reduction of the subchondral sclerosis. So there is definite remodeling of the middle condyle which is collapsed here. So there are some certain other X-rays. You can see clearly the joint space is widened and subchondral sclerosis is reduced, and the shape of the middle condyle also altered. So this is another X-ray. So with this we can improve. Definitely there is a reduction of pain is there, and patient gait is improved, and patient is totally relieved from the pain. But when there is varus deformity, we can do osteotomies I do the open wedge osteotomy, and the main thing is you have to curate the all subconsclerotic bone. So without removing the bone, there is no point of doing the osteotomy. So once you do that, and you can reconstruct the middle condyle, that I named it as genu anacademisi. So in Greek, the anacademisi means reconstruction. So these are the post-op. Okay. So videos are unable to play in this. So patient gait is very much improved. Patient is walking without much pain. And our aim of study is the prevention of progression of osteoarthritis rather than treating damaged cartilage. So thank you.
Good message, Dr. Pramod. It is open for discussion.
No, I don't use that. I don't believe that.
In your medical management.
So I want to say the subchondral bone is playing a major role. So that is getting collapsed with osteoporosis. So the cartilage damage is always secondary to the bone. So why don't we treat this problem first before going for the cartilage repair and doing replacements?
Sir, have you documented the sarcopenia muscle mass improvement in your study? How much muscle mass you have improved?
Yeah. So after unloading the knee joint, you have to continuously stimulate the muscles by your regular physical exercises. You can take the help of physiotherapists. Definitely the improvement. So most of the cases we observe that there is a vastus medialis and quadriceps wasting is very, very common feature. Every case when a patient comes to me, I first hold the thigh and see that it is definitely flabby and reduced mass. So that is the one big key role. It leads to the whole load falling on the knee joint. The fellow who is having the quadriceps wasting, when you ask him to get up from the chair, it takes a lot of time. So he pushes the ground, then he gets up. The fellow who got good muscles, he gets up like that.
Sir, we do agree with your progression of the disease and the etiology and the pathogenesis. But do you consider that reversible of the process can be done at that stage?
Cartilage?
Yeah, the cartilage.
No, we have not done cartilage. That's all.
So does your bone and sarcopenia reversal could help the cartilage to come back to its normality?
Definitely. Because by the time the cartilage may be thinned out, it's not completely damaged. No vertical effects. The thinning can be reversed.
In your treatment of the osteoporosis,
In the
treatment of osteoporosis, you mentioned first teriparatide, and then vitamin D was third and fourth on the list, and above that was bisphosphonate.
Yeah.
It is not clear whether you're giving all of these modalities at the same time, or you're trying the most.
Same time.
Everything you're giving at the same time.
Physical exercises, sarcopenia, and also is part of that.
No, just the pharmacological question is, you mentioned teriparatide, bisphosphonates, vitamin D, everything. Is it all given at the same time?
Yeah. So the two are two different actions. No, the osteoblastic activity and preventing osteoblastic activity. So we have to give both.
Sir, when are you stopping them?